All right. Well, my name is Anthony Hilliard, and I'm the Southern California governor for California. And it was really nice to see our Northern California representation with Stanford and UCSF Fresno. We're really proud of our fellows, proud of our program directors and all they do to ensure that the care received by our Californians is better than anywhere else. And so it's a testament to what you guys do every day. We're happy that you are participating in our Jeopardy competition. We want this to be friendly competition because we are one state. In the nationals, then we can be cutthroat because we want to destroy everybody. I'm teasing, but this should be a lot of fun. I will be your judge today. The quality of the judge is as much as I'm paid to do this, which is free. So I will do my best, but unlike the NFL, I don't have instant replay and I don't have New York to call. So we will do our best, but we're really excited that you guys have joined us this morning. Kwan is our Mr. Trebek, and he'll do a fantastic job, and I'll turn it over to him.
All right, thank you, Anthony. And Anthony reminded me before the competition as well that he's not only going to be judge, but also jury and executioner. So
well, now I think that's putting words in my mouth, Kwan. No, this is meant to be fun.
Yeah, no, of course. So yeah, my name is Kwan Lee. I'm the outgoing Arizona governor, and I want to say thank you, Anthony. Thank you, Liana. Thank you, Megan and Pani, for the invitation to, to be the sacrificial lamb and moderate California. It's very nice to see both teams here, UCSF Fresno and Stanford, and it's especially a treat to see two of our prior Arizona people out in Stanford. Obviously going on to do greater things. It's that's a real treat. So without further ado, I think we should get started now. There's some problem with music on our PowerPoint. So unfortunately there won't be music. But we've already reviewed the rules prior to starting. So we're just going to get straight into it. Okay. And Megan and Pani, you want to just jump in and do a one-line quick introduction as to who you are and what your role is today would be.
Hi, I'm Megan. I'm the Southern California FIT co-chair. I'm a second year at Scripps in La Jolla, California, and I'll be manning the buzzers today.
Great. Good morning, everyone. I'm Pani. I'm a third-year fellow at Kaiser San Francisco. I'm the Northern California FIT co-chair, and I'll be keeping score.
Okay, fantastic. Yeah, and just as a quick shout out to the ACC Board of Governors Jeopardy Task Force, led by Nkechi Ijoma and colleagues who have put together all the content for the Jeopardy competitions. We've made a big effort to make sure that today's competitions for both North and South have been set at the same difficulty level. And so these are all questions from a national data bank. Hopefully we not only will enjoy the competition, but we'll learn something, as I certainly did in preparing for this event. All right, so here we go. Everyone see this? Okay, good. All right, so here we are on to single Jeopardy. I suppose that one of the things we failed to do is decide which team gets to start. So we'll just do a very quick, I don't have a coin with me.
I have a number in my head.
Okay.
It's either an odd or even number. And why don't we let Stanford ask me which number I have, odd or even, and if you guess it right, you go first.
Odd.
It is odd.
All right, Stanford, you have the board. Do you want to turn off the mute on your mic? You're muted right now.
Oh, can we have pill effects 100.
Okay.
Hold on one second, Dr. Lee. I would like UCSF Fresno to also be off mute, I think. Isn't that the best way to do it?
Yes, I agree. Let's leave both mics off mute, both Stanford and UCSF. Okay. Okay, so I'm going to read. Once again, a reminder to the audience, unlike regular Jeopardy, we're not going to allow interruptions prior to the buzzers open at the end of the statement. So I'm going to read now. Aldosterone antagonists, spironolactone, should not be used in patients with serum creatinine greater than 2.5 milligrams per deciliter or serum potassium levels which exceed this level.
All right, Stanford hit it first.
What is 5?
That is correct. So we'll call Stanford team 1 here. Okay.
Okay.
Yeah. So what is serum potassium greater than 5? And I think we are all familiar with this. We're not going to spend too much time on this. We'll get back to the board. Okay, Stanford, you have the board.
Can we have pill effects 200?
Okay, Stanford lights their meds. A 58-year-old man with hypertension, dyslipidemia, and CAD status post recent PCI to the LAD presents the ED with dyspnea. His vitals are normal, except for a bit of sinus bradycardia. His labs are normal with a negative BNP and troponin. His medications are aspirin, ticagrelor, rosuvastatin, losartan. Chest X-ray is normal. TTE shows normal EF. The most likely medication culprit for his symptoms is
So Stanford hit first for the.
Stanford, you answer?
What is ticagrelor?
That is correct. Stanford has it again. Okay, so as we all know, ticagrelor is very commonly associated with dyspnea through its effects on adenosine.
Yeah.
Okay, we're back to the board. Stanford.
Pills effect for 300.
All right. Drug-drug interactions can occur in patients with HFrEF. Provide the correct effect of these drugs on warfarin's INR levels. Amiodarone increases the INR, phenytoin decreases the INR, Bactrim.
Right, I think so.
Stanford.
What is increase?
What is increased INR? Is that right?
What is, yeah.
Yeah, I think, hold on a second. Yeah, that is correct. Increased INR, that's correct. Okay. And that's true, it's CYP effects on drug metabolism, as we all are familiar with. Okay. Stanford, we'll continue to have the board.
We do pills effect 400.
Okay, go. An 80-year-old man with diabetes, hypertension, HFrEF, and CAD presents for evaluation of pain in his perineum that is getting progressively worse. He also noticed a black color change in the skin around his groin. Vitals were normal except for sinus bradycardia once again. His medications are aspirin, Coreg, rosuvastatin, losartan, metformin, and dapagliflozin. The most likely medication culprit for his symptom is
Stanford.
What is dapagliflozin?
Yeah, that is correct.
Yeah. Just our buzzers, we've been having some issues, I think, because we can maybe try again, but would it be possible to switch our device that we're using for the buzzer?
Yes, let's do that because yeah, I noticed that that's quite interesting that
yeah, it's every time. Yeah.
Okay, I'm gonna try to log into this guy.
Yeah, and we did test this before, but for some reason, hopefully this is not a buzzer issue and that internet speed is just simply faster in Stanford.
GG. Sorry for the delay.
No worries. So while you're doing that, obviously with the SGLT2 inhibitors, there is an increased incidence of yeast infections because of its glucose uric effects. In the major trials, even though there was some suggestion that maybe bacterial UTIs might be higher, that does not seem to be the signal. There have been rare reports of necrotizing fasciitis, but once again, that's not a strong signal seen in the very large randomized trial. So theoretically possible. And then very specifically for canagliflozin, there was a slight increased risk of fractures and limb amputations, and that one, the mechanisms, somewhat debated, but that's specific to canagliflozin and was not seen with any of the others, EMPA or DAPA. Should we test again?
All right, I'm going to open the buzzers again.
Okay, I'll do a countdown and then we'll try and race in. Okay, I'll count to 3. At the end of 3, we'll do it. Okay, so 1, 2, 3, go.
Stanford and then UCSF Fresno.
Okay, let's try again just to make sure. 1, 2, 3, go.
UCSF Fresno and then Stanford.
Well, I'm confused. Are you having to push it on go or on 3?
Oh, let's on go. Sorry, on go.
So on your, I'll do it. I'll do it this time.
Okay, go. Yeah, Anthony, go.
Go now?
No. It's on mine.
Yes.
On your marks, get set, go.
UCSF Fresno.
Okay.
Okay.
So we know that it may be finger speed, but the internet connection probably is pretty good. You're comfortable with that, UCSF Fresno?
We are, yeah, just slow fingers.
Yeah, no, I appreciate that. We have the time to make these sort of adjustments in this virtual world that we find ourselves in. So, okay, Dr. Leeds, back to you.
All right. Stanford, you have the board.
Sorry, hold on. Okay, could we do CAD for 100, please?
Yes. Okay. The source of error in this FFR tracing at the beginning of the case is, and here you have multiple choice. Just call out the answer though, you don't have to say A, B, C, or D. A is lack of equalization, B is drift, C is use of a side hole guide catheter, and D is the wrong adenosine dose.
Stanford.
Did you say us? Okay.
What is A, lack of equalization?
Yeah, that is correct. Yeah. So what you see here is the preservation of the dicrotic notch. This could be drift at the end, but in a normal tracing, but given that this is the beginning of the case, lack of equalization is the most likely answer. The other options would have resulted in a dampened PD trace. Right.
We'll do a second round of board for like EP questions.
Okay.
Okay, Stanford.
Okay, could we do coronary artery?
Hold on a second.
All right, before we start, we didn't give him the points for that.
Yes,
Oh.
I saw that. That is a good point.
Thank you.
There we go. Yeah, I just noticed that too. Right.
Hannah, you passed your test this morning. You're paying attention. Thank you.
Yeah,
My one job.
she's had her coffee. I'm ready to go. All right. Stanford, you have the board.
Coronary artery disease for 200, please.
Well, they're systematically moving through. This P2Y12 ADP receptor antagonist should not be used prior to diagnostic angiogram in patients with non-STEMI or unstable angina. A, clopidogrel, B, ticagrelor, C, prasugrel, or D, vorapaxar.
Stanford.
What is prasugrel?
Yeah, that's correct. Yeah, this one's a little interesting. Vorapaxar obviously is, yeah, not the best, but it is not a P2Y12 ADP receptor antagonist. Is it ultimately wrong to use any of these 3 agents? Probably not, right? Because the primary issue is that prasugrel is only indicated in patients who receive PCI, while the other 2 can be used in the initial medical management. But so there's some subtlety to this, but the answer is correct. Okay. I once again forgot to press the button. Okay, we're giving them the points. Now we're returning to the board. All right, Stanford, you have the board.
Can we do coronary artery disease for 300, please?
Okay. All right. This intravenous agent leads to inhibition of factor 10A. A, fondaparinux, B, eptifibatide, C, abscizumab, or D, cangrelor.
Stanford.
What is,
Oh, sorry. Sorry. Go ahead. Yeah.
okay, what is abscizumab?
That is incorrect. UCSF Fresno has the option to answer.
What is A fondaparinux?
That is correct.
It's okay.
What color would you like, UCSF Fresno?
Doesn't matter. Blue.
Okay, blue. We'll put you on team 12 so that I don't accidentally press buttons across the board. There we go. All right. So yeah, fondaparinux reversely binds to antithrombin 3 and indirectly inhibits factor 10A. Eptifibatide and abscizumab are glycoprotein 2B3 inhibitors. Abscizumab was a monoclonal antibody, while eptifibatide is a small molecule. And then cangrelor is a reversible inhibitor of P2Y12. That's IV, right? We all know that. Okay, Fresno, you have the board.
We'll take coronary artery disease for 400.
Okay, continuing into the gradual sweep across. Intravenous monotherapy with this drug has been associated with catheter-associated thrombosis during PCI. A, heparin, B, fondaparinux, or C, enoxaparin.
Stanford.
What is B fondaparinux?
Yeah, that is correct. Yeah, fenebrutinib should not be used as a sole anticoagulant to support PCI because specifically of that risk of catheter thrombosis. In patients who have received fondaparinux, you're supposed to heparinize them as normal. Okay, control is back to Stanford.
Valvular heart disease for 100, please.
Okay, breaking the trend, moving across. Okay, so I'm going to read this slowly so you can get your calculators out. Cardiac output is 7 liters per minute. Using the tracing below, the approximate aortic valve area is okay, I should have pressed the little, I'm pressing the timer thing, the color thing. I think no one wants to commit, no one wants to make a mistake. All right, you should have just opened MD Calc or something.
Hey, now as the judge, that's not okay.
I'm from Arizona, I plead mea culpa. So it's 1 centimeter squared. The aortic valve area can be estimated with the Hackey equation, right? The Gorlin equation is the better equation, but it can be estimated with the Hackey equation, where it's the cardiac output divided by the square root of the peak to peak gradient. And that's why I'm going to go back here. That's why I specifically changed the numbers here. The original question had just to make sure that the number came out nice. So it was 49, you got 7, cardiac output 7, 1, right? Okay, good. That was a fun one. I think Stanford still has the board.
Could we get valvular heart disease for 200, please?
Okay. With increasing severity of mitral stenosis, this happens to the S2 opening snap interval. A increases, B decreases, C no change, and D depends on the presence of concomitant aortic stenosis.
Okay, increase MS.
I'm going to press the timer. Okay, no takers. No responses. Yeah, the interval between S2 and opening step decreases as mitral stenosis gets more severe. It's a classic question, but you know, I think most of us, yeah, the art
Only
of
person I know that can hear that well is Dr. Rick Nishimura.
Yeah.
But
Want to do something else?
all right.
Sure. 100.
Okay, we're doing critical care medicine, 100, please.
100, okay. A 58-year-old man presents with hypotension, increased JVP, clear lungs, and an S3 and auscultation. This is his ECG. The clinical diagnosis is either A, constrictive pericarditis, B, cardiac tamponade, C, restrictive pericarditis, or D, RV infarct.
UCSF Fresno.
Yeah. What is D, RV infarct?
That is correct. Yeah. So his EKG obviously shows an inferior MI, and with the clinical presentation of increased JVP, clear lungs, this is a classical one, and so that is correct. You guys are blue. Yeah. What is RV infarction? We just talked about that. Okay, Fresno, you have the board.
I'll do critical care medicine for 200.
200. The hemodynamic effects of milrinone includes the following: increased cardiac output, increased heart rate, and this effect on systemic vascular resistance.
UCSF Fresno.
What is a decrease in systemic vascular resistance?
That is correct. You guys are in the game. Yeah, I won't go into that. Everything that's pretty straightforward. All right, Fresno.
So
exciting.
we'll keep going with critical care medicine for 300.
300, right. Vasopressin produces this effect on systemic vascular resistance.
UCSF Fresno.
Fresno.
What is an increase in systemic vascular resistance?
Dude, what the?
Yeah, that is correct. Okay, straightforward questions, good. Okay, Fresno.
We'll go with critical care medicine for 400.
Okay. The diagnosis shown by the hemodynamic tracing is A, tamponade, B, RV failure, C, constrictive pericarditis, or D, restrictive pericarditis.
UCSF Fresno.
What is constrictive pericarditis?
That is incorrect. All right. I'm going to put the timer on to see if Stanford wants to jump in.
It's just not that. It didn't probably do.
No. Okay. So Stanford has stayed out of this. Yeah, this one was interesting. This is RV failure, because what happens here, it's the interesting part in the in-between, right? That the RVDP increases is greater than the LVDP during inspiration. Yeah, this cannot happen except in RV failure. So that was a hard one. All right. So who has the board? I lost track there. You guys, who chose that? Was it Fresno?
It's Fresno still.
We chose that one.
Okay, yeah, still Fresno. All right, Fresno, you have the board.
We'll go with preventive cardiology for 100.
Okay, preventive cardiology for 100.
Really good.
The primary mechanism of action of ezetimibe is A, inhibition of cholesterol absorption, B, inhibition of a key enzyme in the mevalonate pathway, C, stimulate cellular fatty acid uptake, or D, increase hepatic production of VLDL.
UCSF Fresno.
Fresno,
What is the inhibition of cholesterol absorption?
that is correct. Yeah. So ezetimibe inhibits intestinal and biliary cholesterol absorption, and can lower LDL, and that's through a transport protein in the jejunal cells. That's the Niemann. It's a long thing. Niemann-Pick C1 like 1 protein. That's a really, I think that's a pretty good, what you call it, trivia fact. I'm not sure how clinically relevant, but it certainly works. Okay, Fresno.
Can we go with preventive cardiology for 200?
Yes. The strongest prognostic variable in an exercise stress test is A, rise in pulse pressure, B, maximum heart rate achieved, C, exercise duration, or D, rise in blood pressure.
Stanford.
We're
Stanford?
going with what is C, exercise duration.
Yeah, that's correct. The interesting thing with this one is that I think exercise duration has to be corrected, right? It depends on the protocol that you use. And so, yeah, the true question is really exercise capacity to that thing. But if you took everybody, all comers for just the Bruce protocol, then yes, absolutely, that equals to exercise duration. But if you started putting people on the Norton protocol, that would be a problem because it's not quite the same. Good job. So, Stanford.
Could we do preventive cardiology 300, please?
300, okay. The mechanism of action of empagliflozin is?
Stanford.
Go ahead. Oh, what is SGLT2 inhibition?
Yeah, correct. Right. These are the drugs of the decade, clearly. All right, Stanford.
Preventive cardiology for 400, please.
The predominant site of PCSK9 enzyme production is A, liver, B, intestine, C, bile duct, D, vascular endothelium.
UCSF Fresno.
All right, Fresno.
What is A, liver?
Yeah, that's correct. Good job. Wow, with that.
No problem.
All right, Fresno.
Another full round.
What is valvular heart disease for 300?
That's it.
Okay, the diagnosis based off this tracing is A, aortic stenosis, B, hypertrophic obstructive cardiomyopathy, C, paravalvular, D, myocardial infarction.
We can do it.
Stanford.
What is B, hypertrophic obstructive cardiomyopathy?
Yeah, that is correct. That's the classic Brockenburrow-Braunwald-Morrow sign, the post-extrasystolic potentiation, characterized by a decrease in arterial pulse pressure after a PVC, accompanied by significant increase in the peak left ventricular systolic pressure. Good. It's a darling of Jeopardy questions. Okay, Stanford, I think you have no choice. We're going to go for the last one here. Valvular heart disease for 400. A 64-year-old man presents with dyspnea and exertion. The audio file, which I don't believe you can hear. Can you guys hear this?
No, can't hear it.
Okay, forget it. Just by look at the tracing, there's enough information here. His abdominal aortic Doppler is shown. The diagnosis is A, aortic stenosis, B, aortic regurgitation,
Okay.
C, mitral regurgitation, or D, abdominal aortic aneurysm.
Stanford.
What is B, aortic regurgitation?
Yeah, that's correct. You can clearly see diastolic flow reversal in the abdominal aorta here. It's unfortunate that you can't hear the audio file because it's a nice sound of
Yeah.
aortic
No.
regurgitation. All right, what is aortic regurgitation? Okay, we're going back to the board and we are now moving on to the double board.
The double board?
There's a double board.
There's a double board. I said there's a single board, there's a double board. So
Oh.
double board. It's not
Just
over yet.
double the points.
Yeah, double
Yeah.
the points.
Oh.
All right,
Yeah.
Stanford.
What are these categories? Hold on a second.
Guess you just do whatever. Have you got
This-
200?
Okay. We're gonna do. Have you got the juice for 200?
Okay, it's time for smoothies. This class of medication is recommended as the mainstay of treatment in patients with a clinical diagnosis of long QT syndrome, class 1, and suggested in patients with silent, genotype positive, phenotype negative, long QT syndrome.
Stanford.
We're gonna say what is beta blocker?
Yeah, that is correct. So what are beta blockers?
Oh, sorry.
Yeah, we want what is a beta blocker? What are beta blockers? The effectiveness of beta blockers obviously vary depending on the genotype. Long QT1 patients respond better to beta blockers than patients with LQT 2 and 3. Okay, Stanford.
Have you got the juice 400?
This Vaughan Williams class 3 antiarrhythmic agent should not be administered in conjunction with thiazide diuretics.
Yeah.
I'm gonna hit
You
this
want to read
color.
that? Oh, sorry. Stanford.
What is dofetilide D?
Yeah, that's correct. I apologize. I should have read all the options. Getting ahead of myself. But that's correct. Obviously, thiazides given just from the pure hypokalemic effect, less desirable, but this is very specific to dofetilide, given its actual renal excretion issue. It does increase dofetilide levels, and therefore co-administration is definitely contraindicated. Okay, Stanford.
Have you got the juice? 600, please.
All right, let's stick in with the juice. Unlike other class 3 agents, this antiarrhythmic
Wait,
agent.
Wait.
Hold on a second. I can't see anything.
Same
Oh,
with
what
that.
happened?
The screen's frozen.
Okay, give me a second. Okay, can everybody see the screen now?
Mhm.
Yeah.
Okay, all right. So I'm going to start reading now. Unlike other class 3 agents, this antiarrhythmic agent increases the defibrillation threshold of AICDs. A, amiodarone, B, dronedarone, C, sotalol, and D, dofetilide.
Stanford.
What is amiodarone?
That's correct. Yeah, this is also a popular, exam question, etc. All right. Okay, Stanford.
Have you got the juice? 800.
All right. This class 1A antiarrhythmic agent is used to treat the rhythm below.
UCSF Fresno.
What is procainamide?
That's correct. Yeah. What you see here is obviously atrial fibrillation with WPWP excitation, and procainamide is recommended as one of your first-line agents for this issue.
All right, we have to give him the points.
Yes, coming back, giving points here now. Good. Okay, Fresno.
It's complicated for 200.
100. It's complicated for 200. The systolic murmur associated with this complication of inferior STEMI can be very soft or absent. A, VSD, B, papillary muscle rupture, C, free RV wall rupture, and D, post-MI pericarditis.
Stanford.
What is B? Papillary muscle rupture?
Yeah, that's correct. VSDs obviously will generate a loud murmur. Free RV wall rupture is no murmur. Post-MI pericarditis is a rub. And in the presence of severe MR, you can have very soft or absent murmurs. Did I give them the points?
No.
No.
Okay, there they go. All right, in the bank. All right, Stanford.
Fine. It's complicated 400.
Complicated 400. The classic triad of this inferior STEMI complication is hypotension, elevated JVP, and clear lungs.
Stanford.
What is RV failure? RV infarct?
Yeah, that's correct. RV infarct, RV failure. And we saw that earlier actually in the first set. So get straight back to the board.
You didn't give him
Stanford.
the points.
Oh, again.
Thank you.
I'm a terrible banker. To be fired. All right, Stanford.
It's complicated for 600, please.
Oh, it's a daily double. Okay.
Okay. Do we tell you the wager? How do we do this again?
Yes.
Sorry. We
yes.
write it down. Wait.
No, you tell me, and I enter it in this box here.
Okay. Yeah. Okay, can we do 100, please?
You will go for the minimum? Okay, minimum. 100. All right. Go. Ventricular fibrillation, which occurs after this duration in hours following STEMI presentation, is associated with an increased risk of sudden cardiac death.
What is this? We can play.
You have to play. Yeah.
Oh, we have to play. Oh, okay.
Okay.
I think it's this. Yeah. Okay. What is 48 hours?
That's correct.
Yeah.
So that good. Yeah. The banking occurred correctly. All right, Stanford, you still have the board.
It's complicated for 800, please.
Okay, in this rapid fatal complication of STEMI, patients develop cardiac tamponade followed by pulseless electrical activity. The vessel infrequently, all right, emphasize infrequently, involves the A, obtuse marginal, B, ramus intermedius, or C, right coronary artery.
UCSF Fresno.
What is the obtuse marginal artery?
That is incorrect. Stanford, you have till the end of the timer to decide if you want to get into this. Okay. Yeah. So, yeah, what is the right coronary artery? The right coronary artery is the artery that's least likely to involve a free wall rupture. The circumflex is territory. The lateral wall is the highest.
Okay.
So a correlate to that, that would be a dominant with a very large branch, right? So
yes, correct. You could get it in a very large dominant, very small circumflex. So that is the corollary. But statistically speaking, it is the right coronary artery.
Yeah.
All right, the board goes to Stanford.
Let's do it. Killing me softly for 200.
All right, ooh, not a daily double.
100. 100.
Okay, super conservative. So you took your lithium today.
Sorry, you're frozen again, I think.
Okay, there we go. Okay. Using ambulatory blood pressure monitoring, hypertension is diagnosed when the average 24-hour BP reading is equal or more than A, 130/80, B, 125/75, C, 110/65, or D, 140/90.
Okay. What is A?
Yeah, okay. That's not correct. And you see why here in a second. So this is from our 2017 AHA hypertension guidelines. What you'll find is that the 24 average blood pressure monitor results corresponding to clinic results is slightly lower. Clinic is an exciting place to be.
Quan,
yes.
We're going to run 3 more questions. It's 10:07. And so we started a little bit late. So it's a 30-minute game. So we'll run to 10:10 and then we'll go to Final Jeopardy.
Okay, we'll do. I'll let you call it.
Yep. So 3 more questions, and then we'll end the double Jeopardy. We'll go to Final Jeopardy.
Okay, Stanford, you probably have 3 more questions to go.
Okay, walk in my shoes for 200, please.
Walk in my shoes for 200. The recommended initial screening test to be valid for peripheral vascular disease is
UCSF Fresno.
Fresno.
What is an ankle brachial index?
That is correct. I'm gonna go back and give that to you, and let's get back to the thing quickly so we can make sure that people have a chance here.
Yes, okay.
All right, Fresno.
Can we do walk in my shoes for 800?
Walk in my shoes for 800. Here we go. In patients with PAD, surgical therapy is generally preferred over percutaneous intervention in this vessel. A, common iliac, B, external iliac, C, SFA, and D, common femoral.
UCSF Fresno.
What is superficial femoral artery?
That is incorrect. Timer goes to Stanford. No. Okay.
No.
It is the common femoral artery, right? All the other arteries. Yeah, that was okay. Stanford, use the board.
To clear or not to clear 200, please.
To clear or not to clear 200. Routine preoperative 12-lead ECG is not recommended. Class 3, no benefit in this situation, and you must be specific.
There's so many.
Turning the timer on. I suspect no one will want to take this. Okay, specifically asymptomatic patients undergoing low risk surgery. All right.
So we'll transition to Final Jeopardy, but the most important question of today for your practice is this one. Don't do it.
Yes, that's right.
That is
Medicare-
cataract surgery.
Yeah, Medicare actually looks at that.
Absolutely, that's a fraudulent thing to do. So let's transition now to Final Jeopardy, Dr. Lee.
Okay, we're going to Final Jeopardy.
Oh, yeah.
Final Jeopardy. Okay, so just to remind everyone, the category is cardiomyopathy. You need to write your wager down, and the maximum wager is obviously the amount that you have in the bank. You know, I think at this point, you know, with the current scoreboard, you know, it probably doesn't. But let's just do it for fun. Write down your amount that you're wagering. Are you guys good? Have you written it down? Yes, yes.
Sorry, how much?
100.
Okay. All right. I'm revealing the prompt. A clinical trial presented in the European Society of Cardiology 2020 meeting demonstrate benefit of this cardiac myosin inhibitor in patients with a condition demonstrated by the tracing. So you need to do two things. Name the drug and the condition. Name the drug and the condition. Write down your answers.
Yeah.
Oh, who's playing that?
Leanna.
You want to write it down?
That's the tracing.
By the tracing.
Okay.
What tracing?
This tracing.
Oh, yeah, yeah.
Okay. Good.
Yep. Yep.
All right. All right. All right. Hold on to your answers. We're going to go to the answer. The answer is mavacamten, and specifically the clinical condition is symptomatic hypertrophic obstructive cardiomyopathy. All right. So very exciting drug, totally new class, right? Cardiac myosin inhibitor. This is a very exciting new field. All right. Show us your answers.
Oh, sorry. Here.
Okay. So you guys wrote, okay, you both wrote just HCM. Yeah, it probably should be symptomatic HOCM, HOCM, because if they're asymptomatic, you know.
Yeah, but I think I'm super impressed at both of these teams to get the drug and the diagnosis.
Yeah, so we'll give it to them.
Yeah, it should be HOCM, but you guys did phenomenal on that last question. Strong work.
Yeah, congratulations, both teams. I'm sorry for the initial question of the buzzer, issue, but yeah, I think so. Overall,
we're going to give as judge, jury, and executioner, Dr. Kwan Lee. I'm going to give them both credit for that answer.
Yes, absolutely, and I totally agree with that. All right, so I think we've reached the end of our round. You know, thank you so much for you know, both teams for participating. Pretty impressed with the level of knowledge here. You know, the winners today are for Northern California. Anthony, do you want to announce that?
Yeah, it's our colleagues from Stanford, and but UCSF Fresno, you should be proud of the work you guys did as well. I'm very impressed with the quality of our fellows up on the northern side of the state. So strong work to both teams.
All right, let's give a round of applause, everyone.
Thank you.
Yeah, thank you.
Have a blessed day, and thanks for taking some of your Saturday to spend it with us. We appreciate it.
All right.
Bye-bye.
Thank you, guys. Good luck, Stanford.
Thank you.
All right, we'll see you. I suppose we'll see you February 12th.
Okay, sounds good. Bye.